Good morning, ladies and gentlemen. My name is Manuela Simoni. I am a professor for endocrinology in this university, and it is my pleasure to welcome you here in this second day of the International Meeting on Asthma, COPD, and Concomitant Disorders. Professor Fabbri gave me the honor to chair, together with Professor Campanini, this session dedicated to clinical phenotype of chronic diseases. And I think we start immediately with Professor Wedzicha from London. She is Professor of Respiratory Diseases at the University of London, and she will give us a talk about clinical phenotypes of COPD. Welcome.
So thank you very much, Professor Simoni, for the introduction. Thank you very much to Leo for inviting us, as usual, for meeting all our friends, for the wonderful hospitality that we've had for the last 2 days, and to all the people in the Gold Committee. It was absolutely superb. So thank you, Klaus Vogelmeier, for that. I'm going to, in fact, talk about COPD phenotypes. I'm going to basically concentrate on a few phenotypes and try and show you some more recent data that has really emerged on phenotypes, including emphysema, fast decliners, and also, of course, I'm going to talk a little bit about eosinophils and tell you some of my views on that. So my disclosures, some of you will know I don't accept any honoraria from industry anymore. It's expenses only from January 2015, and those are my previous lecture fees. So this gives you a rather perhaps jumbled number of phenotypes, and I've been a little bit biased. I've actually put chronic bronchitis at the top, and I'm going to show you some data that I think this is an important phenotype, but importantly, this may be our best marker we have of early COPD. There's no doubt emphysema causes is associated with disease progression, and you can see some of the other things. I've also called persistent smoking a phenotype, because I will show you that treatment differs by smoking. The treatment response differs by whether you are a smoker or not, and I'll give you an example of that. Alpha-1 antitrypsin, that's our genotype, our phenotype, that's one of our most specific phenotypes. And I'm just going to show one or two slides on bronchiectasis, because I think that's an important comorbidity, really, of COPD. So this shows you some data from the long-term azithromycin slide. I'm sorry it hasn't got a title. This is Milan-Hans secondary analysis that was published in the Blue Journal in 2014. And as you know, the study showed that long-term azithromycin reduced exacerbation frequency. And when they looked at the different phenotypes in which type of patients it worked, there was a strong signal, as you can see in the purple, in the ex-smokers, while in patients who were active smokers, which was about 40% of the group, there was no signal at all. So if you are a long-term continual smoker, long-term macrolide therapy doesn't work. So this is important, and smoking affects response to drug. There's also another paper from Steve Bernard on a CXCR2 antagonist that does the opposite. It works in patients who are smokers, presumably because they have more neutrophilic inflammation. Exactly why the macrolide works in non-smokers and not in smokers, we really don't know. So this is the classical description of Erickson of alpha-1 antitrypsin deficiency. In a way, our best phenotype. We know a lot about it. It causes accelerated disease progression, and together with basal emphysema. And and this is a paper from 2001. It actually comes from Rob Stockdale's group, and it was the first really description of looking at exacerbations and disease progression. And we got interested in this more or less about the same time, and this is why I think this was a key paper. And there was no overall relationship between exacerbation frequency and FEV1 decline. Notice the numbers in alpha-1 will always be smaller. However, if the FEV1 was greater than 35% predicted, there was a significant effect of exacerbations on lung function decline, and also there was a relationship shown between FVC. And we know this initially from the UPLIFT trial and other studies that the greatest degree of decline in FEV1 occurs in mild to moderate disease. Once you get to more severe disease, it makes sense because the FEV1 is, of course, much more lower. So an important phenotype is the fast decliner. And although ECLIPSE was not set up to do that, it was set up to look at overall decline and biomarkers, we get some hints at who may be the fast decliners. And you can see here, this is data from Jorgen Vespo's study in the New England Journal, which shows that current smoking, reversibility, and emphysema comes up as an important determinant of FEV1 decline. Exacerbations also affect FEV1 decline. That's actually the decline per exacerbation, and it comes up to around 3 to 4 mils. And if you calculate that over time, that is around 8% of the lung function decline is due to exacerbations. So that's more or less what we also computed. So this is the work of Peter Lange and Jorgen Vespo, and published in slightly different format in the New England Journal of Medicine. And what they showed us, in fact, that you can develop COPD through two ways. You either start off, as you can see in the black and the yellow, with low lung volumes, or you start off with normal lung volumes, and then you become a fast decline. And it's the red one patients that we're particularly interested in. So the green ones decline normally, but it's the red ones. This is where we need to target our anti-inflammatory therapy. We need to find these patients. And to find these patients, we certainly have to look into good old middle age, past age 30 to 50. It will be difficult to find these patients once COPD is actually established. So this is an important phenotype that particularly anti-inflammatory therapy and other perhaps immunological therapies can be targeted at. We know very little about patients who are younger and are smokers and developing early COPD. So the other cause of COPD is, in fact, frequent exacerbations of lung function decline, and this was our work. It was done more or less at the same time as Rob did his work on alpha-1 antitrypsin, and you can see that the frequent exacerbators over 4 years, this was actually done on daily spirometry at home. So this is how many readings we needed over 4 years and around 100 patients to actually show this effect. And when we calculated it, we calculated around 8 mil, or 25% of the FEV1 decline we could attribute to the effect of exacerbations. And what was interesting, the lung health study came up with exactly the same figure, around 8 mil difference between frequent and infrequent exacerbators, and 25% of the lung function decline. So this is important. The fast decliners are an important group. So we know that they probably start off younger. We know they're frequent exacerbators, but also it has effects on other functions. So this is an interesting study. It's recently published from Ulrich Watts in the Blue Journal. That's the big advantage of being the editor. All this comes through me, and I almost have early sight of all the papers and can put them into slides. It's wonderful. And what this shows is decline in FEV1 and change in physical level. You can see increased little change. You can see fast decline on the right and very fast decline in physical activity. And this is related to a faster decline in FEV1. So these fast decliners, I think, is a priority to go after. So this is another paper. This is published now online just. If anybody's interested, I actually downloaded it from line. I have to be very careful also that I don't show anything too early. This is now published online in the Blue Journal, and it's data from COPD gene using inspiratory and expiratory scans. And what it shows is gold 1, gold 2, gold 3, and gold 4. And what you can see, if we start on the right-hand side, that's emphysema in red. As you get more severe disease, you get more emphysema. But what they showed is PRM. This is actually looking at the small airways function. In fact, small airways contribute to disease progression early in the disease. So, and this fits with Jim Hogg's work, who showed that small airways disease was really the first problems. So you can see in early disease, it's the small airways. As you go across, the phenotype changes, and you get an emphysematous phenotype. We also have to remember that phenotypes change, and this is, again, I think, one of the important challenges we have, because exacerbation frequency changes. It increases over time. So and then it changes. Various things will make patients become a frequent exacerbator. So, other phenotypes. This is now going back to the ECLIPSE cohort, and this is actually Steve Bernard's paper. I apologize, I've left the label off for some reason, in Annals of the ATS in the White Journal. And again, they looked at survival, and this was related to moderate functional emphysema. You can see mixed, emphysematous, exacerbator, and inflamed comorbid. And I'm showing you this because systemic inflammation is another very interesting phenotype. If you look through ECLIPSE, there seems to be around 10 to 15% of patients who have persistent systemic inflammation. These patients certainly do worse. However, they are actually our challenge. We don't really have interventions for them, but they are particularly the group of COPD patients that we have most problem with. So, which brings me to Marina Seta's lovely work on chronic bronchitis, and you can see on the right a pathological specimen she published in 1998. I love this. If Marina's in the audience, I actually love showing this slide. I show it everywhere, actually. And you can see the goblet cells. And this is very important. We used to be very interested in chronic bronchitis. Fletcher and Pito based their work on that. And this is some work from Guerra et al. In Thorax 2009. And basically, the blue line is older patients with bronchitis. And it shows you that survival and lung function changes are much worse in patients with persistent bronchitis, and particularly if they are older. But you can see in the red line, age less than 50 in chronic bronchitis, already you have a problem with respect to FEV1 decline. There's two curves. One curve is shown on survival in the paper, and this is the one for incident airflow limitation. So, what about bronchitis and frequent exacerbations? So again, back in 1998, and this is why I've got Marina's slide, we show that two things predicted exacerbations: number of exacerbations in previous year, which was confirmed at ECLIPSE, and also bronchitis, daily cough and sputum. This came out very strongly as a predictor of frequent exacerbation. This is Pierre Bourgel's work, again, showing exactly the same thing. On the left of each subjects with frequent exacerbations first related to chronic cough and sputum, subjects with frequent moderate exacerbations, and subjects on the right with frequent severe exacerbations. Chronic bronchitis, if you've got bronchitis in the stable state, you're more likely to be a frequent exacerbator. And again, these are important patients, and I'll show you in a moment how this affects therapy, particularly with roflumilast. So this is a paper from my group, from James Allison. He's one of our new rising stars, and he put this work together with what's called the 1946 birth cohort in the United Kingdom, set up to monitor our health service. And this is, in fact, only about 2,500 COPD patients that are still alive. But what's interesting about these patients, they've been actually pretty well phenotyped. And at each time point, you can see 1966, 1971, there is data on MRC dyspnea scale and bronchitis. And from age 43, 53 and 60, there is data on lung function. And actually, the patients all being reassessed now at the age of 70. They're having their 70th birthday party next week, because this was recruited as everybody who was born in a particular week, the first week in March 1946. What he showed was this: prevalence of mucus hypersecretion. James showed was that in the red line, that actually bronchitis is pretty variable as it develops. It actually comes and goes, and this paper is also online. But what he showed is between the age of 36 and 43, there's an upstroke. There is an increase in prevalence of chronic bronchitis out in the community, and it rises in the persistent smokers. In the quitters in green, if you see, it actually is very variable. It goes down, it tends to be on the trend down. While if you're a never smoker, there's a very small rise over time in chronic bronchitis. So smoking, and a number of these patients had normal lung function. Further analysis of this data, if you're interested in the paper, shows that it's the people in red who develop chronic airflow obstruction. They develop reduction of FEV1 by the time they get to the last period, which is 60 to 64. So we do have a marker for early COPD, and we need to exploit it. So this is, in fact, the first time, in fact, a proper phenotype treatment was probably used in COPD, except enriching for exacerbations. So this is the effect on roflumilast, PDE4 inhibitor. And what was shown, you'll remember, it's patients with chronic bronchitis and emphysema. They were the ones who showed the biggest effects. So patients just with emphysema, there were no CT scans, but they were really the people without bronchitis. And you can see in all patients there was a small effect, a much bigger effect if you, in fact, look at these patients. And this is why the label for phosphodiesterase inhibitors is actually chronic bronchitis and a history of exacerbations in more severe patients, FEV1 below 50% predicted. This is the REACT data from Fernando Martinez and Leo Fabry and Klaus Rabe were all involved. And there were, this is the analysis on all exacerbations. On the left, the intention to treat just missed significance. But you can see on the right, the per protocol, again, adding, this is now adding phosphodiesterase inhibitors to inhaled corticosteroids, that it actually works, and particularly you see an effect on severe exacerbations. Now, I think this is something we've not focused on enough recently. We think they're hospital admissions, they're a bit more than that. But you can see whether you look at intention to treat per protocol or only exacerbations leading to hospital admission. If you add roflumilast to inhaled corticosteroids, you see a remarkable effect on exacerbations. And this brings us to the point, how far can we go with treatment? And I think we were always under the impression there is a ceiling effect, but actually there isn't a ceiling effect. And you can go quite a way with different classes of compounds. So I'd like to move and talk a bit about bacterial colonization, because airway infection, I think, is an important phenotype. And again, show you some recent data. And this is data that was done from a network in the UK from our group, where we looked at bacterial load by PCR with airway inflammation. And what you can see on the top, that IL-8, IL-1 beta, and MPO all correlate extremely well with bacterial load. Of course, we don't know what comes first. Is it the inflammation or the bacteria? But at the bottom, we tried to look at threshold, and you can see non-LABC, low load, high load. And the high load was actually at 10 to 7 organisms. And there does seem to be a threshold at which bacterial colonization causes a problem. You see these low levels of bacteria, but it's the people with heavy bacterial load where the inflammatory markers increase. So we then try to correlate it, and you can see that we correlated on the left-hand side, the broncho test. This is Rob Stockley's color chart. And you can see that as the broncho test color goes from 1 to 5, there's an increase in airway bacteria, and same on the right-hand side. However, at the bottom, we tried to correlate with CAT scores. We had actually SGRQ scores, and you cannot correlate bacterial colonization with any PRO. But we could correlate, we saw effects, species-specific effects on airway, but not systemic inflammation. So overall, plasma fibrinogen was higher in colonized compared to non-colonized. But when we went down to species, we couldn't see anything. But on the graphs, you can see the sputum data. And what you can see here, broken down, the black is Haemophilus influenzae. And generally, all the organisms, the inflammation increases with increasing bacterial load, but the effect is greatest with Haemophilus influenzae. It's also the commonest organism. So certainly, Haemophilus influenzae is an important bacteria that's driving phenotypes. So this, in fact, just brings us to bronchiectasis, and we showed some years ago that patients who had lower lobe bronchiectasis in COPD. So these were all COPD patients who had CT scans, and the bronchiectasis was mild, but we saw greater effects on sputum IL-8. this is data from Barcelona where a longer-term study was done, a follow-up, in fact, over 100 months, and what they showed was that over time, if you were without bronchiectasis in the dark line, you had a much better survival, 86 patients, than in patients with bronchiectasis. So the comorbidity of bronchiectasis in COPD needs to be found out and managed. So this brings me a little bit to frequent exacerbators, and you can see that this is a slightly different format than what's in the New England paper, and you can see in gold stage 2 already, 39% of patients have at least one exacerbation, and this increases. But why do patients get frequent exacerbations? And this has been something I think that we've been interested for some time. And what we show in this study is, in fact, that if you are virus positives, that's HRV positive, you have more exacerbations. If you have one exacerbation as HRV positive, you're more likely to be a frequent exacerbator. And on the right-hand side, that's the important curve, as a patient gets more exacerbations, each time they get a higher viral load, so they acquire more virus. So you're more susceptible to viruses, and I'll come back to that at the end when I talk about eosinophils. So if you're a frequent exacerbator, you're more likely to acquire viral infections. And this is, in fact, the impact of COPD exacerbation. You can see it has an enormous impact, including depression, comorbidity, and more hospitalization. And this is the ECLIPSE hospitalization data. You remember this, in that patients in ECLIPSE who were hospitalized in the first year, followed over the following 2 years, did much worse. Again, this is our severe exacerbations that really need focus. However, phenotypes change, and this is a very good example of factors associated with change in exacerbation frequency, and you can see what happens from 1 year to the next. And after 1 year, 39% of patients who were frequent exacerbators changed, and 17% of our infrequent exacerbators. So phenotypes change, and it depends on environment, on viruses. And the only thing we could show was that if you reduced your systemic inflammation, if you were a frequent exacerbator, you moved to being an infrequent exacerbator. So doing something to systemic inflammation does work. It does seem to change your exacerbation status. I'll move on with this. Let me just move on to this. So exacerbation phenotypes. And in addition to COPD phenotypes, we also have phenotypes of exacerbations. And this is some data from Mona Baffadel, when she was in Leicester, when they looked at the different phenotypes of exacerbations that are available: bacteria, predominant, eosinophil, virus, and non-inflammatory. And they showed that there were a group of people who had eosinophil predominant exacerbations. Now, it's not quite what we see. In my group, most patients have a neutrophilic event when they have an exacerbation. But what you see often is that all the bacteria increase, including eosinophils. So we don't see so many eosinophil exacerbations. Is this a feature of ACOS? And I still think that neutrophilic, the IL-8, the IL-1 beta, the MPO, these are the most important. These were the figures, in fact, that they showed us. We see much less exacerbations where we don't see neutrophilic inflammation. But there's no doubt there are some patients who have this eosinophilic pattern. Now, the whole eosinophil phenotype has come to importance recently because of reports that the effect of inhaled corticosteroids is related to blood eosinophils. And this is the data from PASCO based on the RELVAR study. So this is fluticasone and vilantrol. And as you can see at the bottom, as the eosinophil count increases, you actually get more exacerbations.
Could you please come to the conclusions?
Yes, I am. I'm finishing now, actually. This is my last slide.
Thank you.
And what you see is that in blue, though, the patients on the LABA ICS actually have the same frequency regardless. And the same thing was shown if you look at the Chiesi study, which was formoterol and beclomethasone. So actually, what eosinophils are doing is giving you more exacerbations, but actually the effect of the ICS seems to be the same regardless. Now, what I just want to show very quickly is another paper, which you may have not seen, from Jürgen Vespo and Peter Lange from Denmark, who looked at eosinophils in the population, COPD by spirometry clinical COPD. And if you look, they saw that eosinophils were higher on the right, where patients had severe exacerbations admitted to hospital. Where there were moderate exacerbations, the eosinophil levels were actually much lower. So we really need to go back and look very hard and study this a bit further. I think at the moment I would not give ICS just based on eosinophils. As I showed you, the effect is actually the same regardless of the level of eosinophils. It's just that you get more exacerbations where you get a higher eosinophil level. So I've shown you that there are a number of observed phenotypes. I've shown you that these phenotypes have changed, and I've shown you that some of these phenotypes are useful in guiding therapy. Thank you very much indeed.